Me. I'm really excited. We're here to talk about Lyme Awareness Month. And throughout the month, I've had some really amazing guests, which is super cool, because people have taken their time out to really share different things to help you kind of minimize your risk of getting a tick bite, help you understand what to do if you did get bitten by a tick, and then, move on. And it looks like my camera is the wrong one right now. So let's fix that. Sorry about that. I'm looking at the black screen. I love it. Technology is an amazing thing. So anyhow, one of the things we're talking about this month is really about prevention of tick bites, like I was saying, and then maybe if you want to do prophylactic treatment. And then with Dr. Alexis Chesney, and again, we talked about her book, Preventing Lyme and Other Tick-Borne Illnesses. It's a great resource for you. The other thing, and so tonight, one of the things I'm going to do is I'm going to dive a little bit more into the way I look at these, about how much Lyme's around, what we really need to do, and how that can help us. The other part we talked about was all things Lyme with my buddy, Dr. Darren Engels. My fingers like to block their names a lot. But he wrote the Lyme Solution, a 5-part plan to beating Lyme. But really, we focus not only on the acute treatment of Lyme, both with medications and herbs, but also the fact that we have to look at other things in our bodies. We have to look at things like autoimmune processes. And a lot of these things can really be controlled with our diet and our lifestyle. So you have a lot of power. And that's one of the things I really want with this Lyme Awareness Month is everyone to understand that you have the power to minimize your risk of getting Lyme, but you also have the power to optimize your health prior to getting it. And if you do happen to have it, you have the power to optimize your own health and your own healing. So rather than viewing ourselves as sick people, or we are people in the process of healing if we have Lyme. And certainly if we're healthy at the moment, we are continuing to be healthy. So for tonight, one of the things I really wanted to do is just kind of drop in and talk a little bit about how much is going on with Lyme here. And I've got two windows open here so I'm going to close that real quick. So I can only have one on the screen. We don't need double. And really one of the questions that we have is how common is Lyme disease? And the thing is, it's been estimated in the past that there's only like 35,000 cases per year. And then it was estimated that was a tenfold underestimation. And now so that was around 350,000 cases. We're now looking at potential of 475,000 Americans that are newly diagnosed and treated for Lyme every year. And this is from the CDC's research. And so that's an important thing because the old data was really looking at, absolutely confirmed cases from the CDC for research purposes. But this is like what doctors are actually seeing and diagnosing and treating in their offices. And this isn't just, the people who go to the doctors who think chronic Lyme is the cause of everything. Because all the doctors I know who would get lumped into that category by some other physicians, that's not what they feel. But we are seeing a lot of Lyme out there, but there's not enough doctors to make that number go that high that are in this small minority of people who have been called out. This is family practitioners, internists, pediatricians, a lot of them on the East Coast where Lyme is so prevalent that are diagnosing and treating people clinically for Lyme, often before you can even get a test because that's the right time to do it. So this number is really telling. The other thing is we see that there's all these case reports of Lyme really do sort of, you can see on the map here where the highest incidents are, where all the blue is. And it really is at the Mid-Atlantic and the New England states as well as the upper Midwest. Now, the thing is there have been cases of Lyme reported in all 48 contiguous states. And we see that other states are growing rapidly. So again, the other part we have to remember here is lots of things travel, and particularly people are traveling and also birds are traveling. So I've seen people in Oklahoma, which you can see on the map, doesn't have that many, cases of Lyme really. And in this case, almost none. But the issue is birds are migrating. They're having infected ticks on them. Partially fed ticks are dropping off and then biting people. I have colleagues in Oklahoma with that exact scenario. So it's not the most common thing, but it happens. And people from all these other states travel. Lots of people go to the Cape. They go to New Jersey. They go to Maine and all these other areas for vacation, visit family and friends. You might be hiking in California. And while it's not the number one place, it's one of the fastest growing places for tick-borne illness. So we need to keep that in mind. the other thing is just these are the probable and confirmed cases that follow that research data, that really stringent CDC criteria. And it continues to go up as we see global climate change and we continue to modify our environments. The thing I want everybody to really know about, though, is that children and those in the middle ages are really the ones who are at highest risk. And especially we see our 5 to 15-year-olds. This is a pretty significant issue. And so one of the things to also point out when we look here is that boys tend to be a little more risky than girls in here. And this, could be what they choose to play with or not, or the fact that maybe they're a little less compliant as I was as a kid with tick checks and things my mom and dad wanted me to do. But keep in mind that these are the higher risk groups. And so just be aware of it. Nothing to be afraid of, just know. But also know that those of us who are in our 40s to 60s, we're also in a pretty high age risk group. Now, the other thing, it's like, let's look throughout the year. When is Lyme reported? Well, Lyme's reported every month of the year. And, we're going to look a little later at like the life cycle and everything. But one of the things that's really important to understand is that we have this really higher tick activity in the summer. So we have these peak cases. But there's a lot of times where we see another peak in October and November. And the problem then is lots of times we're not getting just early Lyme. We're getting a little bit of symptoms, whatever. And we don't get it until we get that late disseminated Lyme. That could be weeks to months later and even longer sometimes. So you could be seeing your acute Lyme present in December, January, February, and it can often get missed. Plus ticks are active at that time, just not as much. Then there's this question of, what is going on in terms of, the cumulative number of cases of this thing we call post-treatment Lyme syndrome, right? Because there's so many people get treated, and there's a small number of them, probably 10 to 20%, maybe less, hopefully less, that after they're treated for their Lyme, they have ongoing symptoms, right? And so through the research, we found that this is real, and I'll dive into that a little bit. But post-treatment Lyme syndrome is what the name that some of the researchers has given it to try to figure out what's going on, and they've just figured out that this is a real scenario. The other issue, though, with this is that it could also be not that there's just post-Lyme syndrome, some leftover something that we don't know about, but it could actually be that a lot of these people have persistent Lyme disease. And we have a lot of data that supports that. But the scary part here is, when you look at the estimates that come out of this study from Brown, we find that there's a very large number of people, almost 2 million people by the end of 2020, that were estimated to have post-treatment Lyme syndrome, like I said, much of which could be persistence of Lyme disease. This is an unacceptably high number. This is crazy, right? So this is a really high-risk type of situation. So most importantly, as we've been talking all month, and in addition to doing these sort of public awareness sort of talks with Dr. Chesney and Dr. Engels, I also did a series for practitioners. The number one thing we want to do is we want to prevent. We want to prevent Lyme disease. And if we happen to get it, we want to treat it, but just not treat it for some willy-nilly period of time. But we want to do the best we can to apply the best evidence that's available, because the evidence for how long do we treat acute Lyme is questionable. So we have to look at the individuals in front of us, but we really want to treat them to eradicate disease. I think this is a really important piece. So the thing to remember is Lyme is paradomestic. So this is something that basically means about 75% of people are going to get Lyme in their yard or their neighbor's yard. Not hiking in the woods, not going off playing somewhere, but it's going to be in somebody's yard. Ticks and mice, the mice that they happen to be on commonly, love the edge. And the edge is this area, this beautiful preened area. It's about 10 feet. So the edge is literally what it sounds like, right? So if you look at the connection between the woods and your lawn. And so it's 10 feet from the woods out into the lawn and 10 feet deep in, because this is the area where the ticks can live. It's going to have some leaf litter. It's going to have some cover. It's going to have some moisture. And, it's going to be the area where a lot of their meals are, like things like deer and mice, and particularly mice and chipmunks. So this is great habitat for all those things. And one of the issues is we end up doing things like putting our swing sets right near where the ticks love to be. Because the issue is when they come back out into the sun, they can't handle that. They like moisture, they like warmth, but they like dark warmth, right? And so one of the things we can do is we can move our swing sets out in the middle of the yard. This means we might need hats, we might need to put on some longer sleeves, or we might need to put on some extra sunscreen. But this is a great way to minimize our risk, because if we go to the back of that photo on the left, all the way to the back near the woods, we're going to run into a potential problem like the one on the bottom right, where we're close. And it's not that the ticks are coming down or flying out of the trees. They don't do that. But that low brush on the bottom right there is a great area. You brush up against it, there can be a tick. The ticks can crawl around, and they're pretty safe in even in that stoned area there under the swing set, and especially in our gardens and in our leaf litter or in our mulch and all that. This is great tick habitat. So just keep that in mind. We might want to minimize that, or if we spend time making our yards look beautiful and stuff, just remember that that's a time where you want to be more preventive. Now, this is from the Connecticut Agricultural Experimental Station, and I was trying to figure out Mr. Stafford's first name, which is Kirby. It just came to me. That's what I was, and he did a great drawing way back in 2007. It really just shows how that 3-yard or about 10-foot migratory zone where the ticks are able to live, and so we want to get a little further away. So you see, he moved the swing set and he moved a lot of these areas, and we put in, some areas that would be a little bit better in our yard. So definitely check out, you can just look this up, the Connecticut Agricultural Experimental Station, just look up Lyme disease, tick bite prevention, something that it always pops up. The CDC even references this. It's a great, great reference material. It's a free PDF download. One of the things that I do is I actually use a tick control system in our yards, and we get sprayed 2-3 times a year at the high tick rates, and we put out these tick boxes. And these little tick boxes are really cool because what they do is they put fipronil or top spot essentially on top of the rodents, and within 2 years we can get the percent of infected ticks to below 2%, which is spectacular. And also, I like DEET-free natural insecticides because they work better, and DEET, if you spray it on a plastic Band-Aid, will actually melt it. So if you ever get a plastic Band-Aid, spray some DEET on it, wait a second, rub it off, you'll actually see it rub off. So that's another thing. And so we're using cedarcide, and there's some others, but these definitely work. Permethrin is really good to spray on your clothes. We even use it in the treatment of things like scabies. It would be in a different formulation. For humans, it's a prescription. This stuff is toxic when it's wet. We definitely don't want to be dumping it into water sources or spraying it where we could have runoff, because it definitely is something that could mess up fish and kill aquatic life. But once we get it on our clothes, especially on our pants, our socks, and our shoes, non-toxic when it's dry and it lasts for like 7 or 8 washes. We could certainly have a professional company do it for us where they would treat your clothes. You can send it off to Insect Shield, shove it into a bag, and just get as many clothes in there as you can. When they do it professionally, it actually lasts a lot longer. But again, like with this kind of application, I do it because the beauty is I end up getting really good coverage of my shoes and my socks, and that makes a massive difference if we treat even just those. And again, Insect Shield and all the treats with permethrin, and we can block a lot of these other bugs that we get. And I star lice there because lice may transmit Bartonella to people, and that's a big problem also. And we don't want to be doing that. So if we can minimize that, that'd be great. It's not like we're going to send our kids off to school and stuff in permethrin covered clothes, but certainly it helps protect. So that's an important piece. The other thing is, I like compression clothing. You don't have to get the super duper athletic stuff that's really good that for during performance or after performance recovery that's really hard to get on. But just, you can get the sort of the athletic shirts and shorts that are really tighter fitting, that are modeled after these really higher end compression shorts, because it provides an occlusive layer, right? And the ticks are walking up us. They're looking for dark, moist, warm areas. So like your groin, like your armpits, like your behind your ears, in your hair, and in your ears. So in terms of the shorts, this is one of the best things you can do when you're going outside is just because you'll prevent them from being able to actually get into your groin area. Same thing, if you want to put it on your shirt, that's great. And then the other thing is take your clothes off, put them in a bag, or better yet, throw them right in the dryer. Usually, if you have like a propane thing, it's going to take like 15 to 20 minutes. If you have electric or natural gas, it may even be as little as 5 minutes. We just want to desiccate these ticks. And if we put them in the wash first, not going to be as good. The other thing is I take a shower right away because it helps me wash off any ticks that might be still walking around, because often they'll walk around for hours before they'll actually start to try to attach. So take advantage of that and rinse off. And then certainly tick checks are really good. If you're going to do a tick check, you should know what a tick looks like, and especially a deer tick. On the right, we have the female deer tick. On the left, we have the nymph. And the nymph tick, let's see. It's about the size of a poppy seed, and it ends up giving people Lyme about 90 to 95% of the cases because it's so small. So let's take a look at it. And in this picture, there's a tick. And this is from tickencounter.org at the University of Rhode Island. It's their photo. And what you'll see is that there's a tick on this bagel with poppy seeds, right? Easy to find, right? Let's blow it up a little. And as we really, really zoom in, we can kind of get a sense of where it is. But I kept those poppy seeds on the side to just kind of remind you that we really zoomed in here, right? And so it is a pretty small thing. But so if you see a walking poppy seed on you, probably not a poppy seed. Transmission, certainly typically felt to be 36 to 48 hours. That's based on like zero science. One of the things that we see here is that animal models show less than 16 hours transmission can occur, and really the minimum time of attachment really hasn't been established. So this is just an important piece to remember that we don't know. Now, based on all the research I've seen, most of the time, the nymph is going to feed for about 4 days. The adult's going to feed between 5 and 7 days before they fall off. Within the first day for both of them, it's typically going to be more like less than 5% transmission. But less than 5% is not zero. So it's just something to consider. And certainly we know that things like anaplasmosis are quoted as little as 8 hours. And there are certainly at least 3 cases in the medical literature of under 24 hours. And I have a case like that was declined for publication because the readers didn't need to know about it. So doctors didn't need to know that Lyme could be transmitted in less than 24 hours. I think that that's a travesty, but that's kind of what happens in medical publishing. Other ways to get Lyme. Look, there is confirmation of maternal fetal transmission. It's uncommon, but it is possible. Breast milk, we can find spirochetes in breast milk. We have no evidence that means it is transmissible. There are no cases, to my knowledge, that breast milk transmission occurs. People have looked into sexual transmission. It does not appear that happens. I know a lot of people clinically feel that it may. When you look at the data, it's very scant, and it doesn't really completely support that happening. So again, we have to treat the individuals in front of us. Sexual transmission, from most of the experts I've talked to, and my feeling is it's possible, but it's not probable. In some cases, maybe. But again, 99.99% of the time, we're getting Lyme from a tick bite. Blood transfusion transmission of Lyme has not been reported, but it's been reported in babesiosis and in anaplasmosis. There's one case report from something like 1996 of a horsefly probably transmitting Lyme. You can find mosquitoes that have Lyme spirochetes in them. They do not have a mechanism to keep the spirochete alive for more than about 4 or 5 hours, and they don't have a mechanism to transmit it to us. So you'll hear a lot of people talking about, hey, it's in mosquitoes. True. Does it transmit it? We have no evidence not convincing evidence that actually happens. So if you're bitten by a tick, the big thing we need to know is we want to grab it as close to the skin as possible, right at the mouth parts, where it's at the skin, lift and hold and just wait. Because the reason we want to do that is the hypostome, where that mouth part is embedded in us. And you can see it's got those reverse barbs on it. So we don't want to go crazy with it. Just lift and hold, and it will, if it's been there for a little bit, it might take a few seconds. If it's been there for a longer time, it might take a lot longer. So one of the things that I just want to remind everybody is we don't necessarily need to just be cranking this thing out. And this could take a minute or two to really get that to let go. So just lift and hold, no big deal. And then what? Well, the big thing that we want to think about here is, do we need to do preventive treatments? And really the thing to remember with this is that that's a discussion to be had with your medical provider. Typically, I would recommend that if you've been bitten by a deer tick, that you can, especially if you're in the Northeast, Mid-Atlantic states, areas where Lyme's endemic, that you really look at doing prophylactic treatment. That can be done with medications, that can be done with herbals, and talk to your provider about that. Now, the thing is, a lot of people want to know, hey, what's the data behind all this, right? Well, there was a study where they talked about single-dose doxycycline, right? And it was reported to have an 87% efficacy. But the problem was that's in preventing a rash. And the erythema migrans rash that's most common, and that's the diagnostic rash in Lyme, is not something that always occurs, right? And so during that, the literature, well, the CDC says about 30% of cases it's absent, right? So meaning 70% of people have an erythema migrans rash. The other problem, though, is when you look at the medical literature, it's kind of between 40 and 60%. So if we call it 50% of people get a rash, that's problematic, because now we're giving people a treatment that may or may not actually mean that we prevented Lyme, because not everybody gets the rash. They were able to identify cases of Lyme without an erythema migrans rash in there. And the problem is treatment failure, meaning, if we partially treat you with a quick dose, a double dose of doxy, could lead to blocking an antibody response. And then you could have what we call seronegative Lyme, meaning that the blood test was negative. And when the blood test is negative, now we have no rash and we have negative blood tests. And so we're kind of left with symptoms. And there's all this argument, hey, when you're diagnosing by symptoms, really you need to get the lab test. And that's not how medicine usually goes. But now we're trying to give you a treatment to prevent it that's actually just messing up our diagnosis. So it's kind of crazy. And one of the biggest things that bothers me is we've tried to generalize this to other antibiotics. You can't. You can't go to your pediatrician and get a double dose of amoxicillin and say that treats Lyme. That's not been studied that way. So I'm not in that camp where we would want to do that. The other part is we've looked in mouse studies, which is the next best studies we have, and a single dose of doxycycline was a whopping 43% effective in preventing Lyme disease. And then if you had a tick that had both Lyme and anaplasma, it was 20% effective in Lyme and 30% effective in preventing anaplasma. So co-infection is problematic, and so is a single dose of antibiotics. Now, we do have a study with long-acting doxycycline in mice. It's equivalent to about 19 days. Prevented Lyme 100%. They did it again with Lyme and anaplasma. It was 100% effective. So many people that I know are talking about, if we're going to do a prophylactic treatment, do it for at least 20 days, and potentially even extending that out to 4 or 6 weeks, depending upon the circumstances. And again, we don't know the right answer, because the evidence just isn't out there. But that's the closest thing. And so when you see doctors recommending a 3-week course of doxycycline, that's why. Because we're doing the best we can based upon that mouse study. Let's see, I'm going to close that one, because the other thing is, like, that's great. And if you do prophylactic treatment and everything works out, beautiful. Oh, the other part before I jump to the other one is I wanted to mention it is really important to understand that this can also be done herbally. Now, the herbal prophylaxis is actually been, it's not well studied in the medical literature, because most of our medical literature is not looking at those things, right? But we have clinical use with naturopaths and other functional medicine doctors and others where we see this very effective. You can see a lot of this summarized in Dr. Chesney's book. We all have a different approach to it, but the bottom line is, if we get bit and we quickly, within maybe the first 3 to 5 days, preferably start that preventive treatment, we can move on, and then we just keep an eye on those symptoms and we reassess our patients. And, the other thing is, we can't overuse antibiotics. Well, no, we shouldn't overuse antibiotics. But I have people in my family who have been given minocycline for 4 and 5 years for acne. And I'm not opposed to doing it for that, but their acne wasn't horrible. And it was acceptable to do for that duration of time because it was for vanity and or preventing scarring. That's fine. Why can't we do that for a tick bite? Because chronic Lyme disease or Lyme disease at all can be a lot worse than having some scars in your skin from some acne. So I'm not saying don't use it in acne. I'm just saying, why can't I do 3 weeks to prevent a problem, right? And our goal in medicine is primary prevention. And if we get bit, we want to prevent getting the disease, not prevent getting worse disease. We want to just try to knock it out right away. So anyway, the other part we want to look at, like throughout the year, the eggs are laid in the spring, the larvae hatch. If they have Borrelia miyamotoi, that's like 30% of that goes through the larva. But larval deer ticks from getting Lyme disease, which is Borrelia burgdorferi, would only be about 3% or less. So it's very uncommon. The larvae don't really look for us. They're small in the leaf litter on the forest floor. So they're really looking for mice, maybe some birds or chipmunks, but really, really those small animals for their first blood meal. And then they overwinter and they molt and they're a nymph. And then the nymphs are really coming out kind of in the summertime. We're just getting in the New England area, we're starting to see a lot of nymphs coming out now. And so we see that we have, the adults are active in that springtime, but then also much more in the fall. And so this is kind of that 2-year life cycle. One of the things to remember is that the larval activity peaks in August. Nymphs are out in the summer, and spring and fall are the adults. And this is really that EM or bullseye rash we talked about. So this is the Erythema chronica migrans rash, the bullseye that really just most people shouldn't be missing. And these are the data, the statistics I went over earlier. The issue, though, is not all Lyme rashes or Erythema migrans rashes look like a bullseye. This is from dermnet.com, and this is an Erythema migrans rash. It's like a red blotch with some central clearing. That's kind of sort of like Lyme, but this is just a red blotch. This is a physician-confirmed Erythema migrans Lyme rash, but it doesn't look anything like a bullseye. Here, we have multiple bullseyes, because a lot of people are like, oh, it's got to be at the site of the bite. No, actually it doesn't. Even one rash doesn't have to be at the site of the bite, but you can have multiple rashes. Then we have this one. This is actually not Erythema migrans. This is ringworm. And I've actually had people come in with rashes like this all over their entire body. But the difference was they weren't flat like this. They didn't have this appearance. They had more of this appearance. And you can see on the edges here, there's some dried skin. The skin's lifted up here. And this is really classic for ringworm. And I've seen people go to their doctor and beg them, hey, I've got the one that, not this, because this is Erythema migrans rashes, but it looked just like this, except with this dry, scaly pattern, and they got put on doxycycline when really what they needed was ringworm treatment. So I recommend we go bring these things to our doctor's attention, but then we also let them evaluate it and, to be able to tell us, hey, this is a Lyme rash or this isn't a Lyme rash. Here's another example of a Erythema migrans Lyme rash, and you actually can see another one over here, and then there's the rest of it. So these are 2 Erythema migrans rashes, and you might even have another one down here starting, and that's consistent with Lyme disease. So our classic presentations are things like the early, days to weeks after a bite, we get early localized, and that's where we get that summer flu. If we're going to get a rash, we often will get it then. Later on, we're going to get things like neurologic and cardiac, potentially ocular symptoms. Again, this could be early disseminated. But the months to years later thing is where we don't get that diagnosis and we get serious arthritis and neurologic issues. And I just summarized a couple of these, because you do get like different cranial neuropathies cranial nerve palsies and stuff, and cranial nerve involvement with Lyme, especially Bell's palsy, especially when you get that droopy face. That can certainly be part of it. And you can have neuritis, and also, you could get Lyme meningitis and things like that. So just if somebody ever gets Bell's palsy, viral is one of the favorite conversations we have with people is like, oh, it could be viral. It could also be Lyme disease, and that's a really common one. So keep it in mind. Again, a lot of cardiac stuff can happen in Lyme. And you're going to read about these in the newspaper and all, in the couple summers ago where multiple people died of Lyme carditis. But that's not the most common thing. More commonly, what happens is, again, another cranial nerve is involved, the vagus nerve, or the brainstem where the vagus is coming out is involved with Lyme. And then we see that vagal tone that controls the heart and the heart rate and keeping it a little slower is changed by Lyme, and then the heart is beating faster, not because Lyme's in the heart, but because it's affecting the nerve, the cranial nerve, the vagus nerve that would be the one that's bringing the heart rate down. So there's a couple different reasons you could have heart issues. More commonly, these are the things we see, the flu stuff, the joint pain, the muscle pain, the brain fog, numbness, tingling, all that kind of fun stuff. Again, there's heart palpitations and maybe even shortness of breath. I see a lot of GI things too. I mean, this is a soft tissue organism. It likes to get into the wall of the gut, and we have biopsies to confirm that Lyme actually does that. I've seen other people have multiple food allergies. You treat their Lyme even with an antibiotic and it gets better. So lots of different things. Lyme being called the great imitator. These are some of the more common things we see clinically. One of the things I think is important to look through the evidence, and Dr. Horowitz did a really great study on his multiple systemic infectious disease syndrome questionnaire. And this is a questionnaire that he applies and a lot of people use if we think about Lyme disease. Really, some of the key things came out is migratory joint pain is really common in Lyme. You could have some migratory numbness and paresthesias. We see this in Bartonella too. I see that that's a little less strong than the migratory joint pain, because the migratory joint pain is a hallmark of Lyme. There's only a few other things like inflammatory bowel disease, ulcerative colitis, Crohn's, gonococcal arthritis, and some of the hepatitis infections that could cause this. So when you see your physician, and you have migratory joint pain going from one joint to the other, there's not a lot of things that they have to worry about, right? So this really can help them. And again, we go back to published medical literature. It's so important to do this because we do have the evidence out there. And so these are things that can be used to really help us understand. Again, migratory joint pain is the real big thing here. The other thing is in kids, about 50% of them have a GI complaint, right? And sometimes we'll even see kids with isolated abdominal pain. They've done all the GI workup, the endoscopy, the colonoscopy, tried everything. They've done esophageal manometry and all this stuff. And then it turns out that really what happens is that Lyme is a contributor or the actual cause. And we can treat them for the Lyme disease if that's been diagnosed. And then often that GI stuff will really calm down, and sometimes relatively quickly. And the other thing that happens is neuropsychiatric presentations. We get acute behavioral changes, regression in behavior, writing, reading, all this, and even tic disorders. And oftentimes that's a clue to us that we've had this infection-induced autoimmune encephalitis, and that is what we call PANS and PANDAS. And PANDAS would not be in Lyme because PANDAS is a strep-specific thing. But PANS is sort of that broader term saying that the infection is triggering this change. And that's pediatric acute onset neuropsychiatric syndrome. It's basically autoimmune phenomena that's been triggered by infection. So just something to keep in mind. So Lyme is a clinical diagnosis. We support it with our lab data. So one of the things I always say is if it looks like a duck and it walks like a duck and it quacks like a duck, most likely a duck. We shouldn't be in Connecticut or Maine, Vermont, Pennsylvania. If it looks like Lyme, we probably need to consider other things. Not probably, we definitely need to consider other things than what we docs call a differential diagnosis. But at the same time, this should be very high on our differential, and it probably should be one of the first things we think about. Because when we pull labs aren't really great. And there's actually been studies of this because a lot of people want to do this. The CDC recommends 2-tiered testing, right? That means we do a screening antibody test followed by a Western blot. And sensitivity and specificity, kind of in kind of basic terms, means specificity is if I say you're positive, you're really positive. And sensitivity is if you are positive, I'm going to find out that you are, right? So sensitivity is going to pick up the people who have the disease, and specificity is going to rule. If the test is positive and we have a high specificity, it means we're not bringing in people who really don't have it. So the problem being here is sensitivity of 56% is pretty bad, because what that means is that if you take 200 patients that truly have Lyme disease and you test them, you're going to miss 88% of them. You're going to miss the diagnosis 88% of in 88 people, which is 44% of the time. HIV testing has a sensitivity of roughly 99.5%, which means you only miss 1 out of every 200 cases. If I flip this and I said, hey, there are 88 out of 200 people with tested for AIDS were missed, that would be huge problems, right? So we need to change the testing in Lyme. And people are actually working on this, which is great. The question is, what's one to do? And, one of the things that we should be looking at doing is sitting down and understanding the different, approaches, the different symptoms, working with providers who have this knowledge, right? Because what happens is we have basically 2 different treatment viewpoints. We've got the standard viewpoint, which is we need a single antibiotic. We probably need 10 or 14 or maybe 21 days. There's probably not a big difference. And unless you have something extreme, you only need 1 course of treatment. Every once in a while, if you have heart block or a Bell's palsy and we pick it up, or meningitis, we're going to give you an IV treatment. We might even extend it to 30 days, but maybe even a little longer, but that's kind of it. And then we just say it's all over. The other, there's another sort of treatment viewpoint, is that we may need a duration of treatment that's longer. We may, because of the way Lyme can hide in the body, use different antibiotics that work in different places. We might need a longer course of treatment, and we may want to add in some of the natural treatments to it. And over the last year and a half or 2, we've really seen just a ton of research coming out, especially from Johns Hopkins, showing that our herbals for some of these, what we call persister forms, the things that would allow Lyme to stay in you longer than just that short course of antibiotics would cover, our herbs can actually do a better job than things like doxycycline and cefuroxime, which are drugs that would fall into the category over here. And, even some of our other infections like Bartonella, we're finding out that things like azithromycin and doxycycline are not as good as the herbal treatments. Doesn't mean we should throw out our antibiotics, but there's this role for bringing them together. And then, as we talked, post-treatment Lyme syndrome, people question, maybe the residual symptoms aren't related to active infection. We have some permanent or temporary damage, persistent inflammation. My problem is, if you're on a treatment and all your symptoms go away, I stop the treatment, all your symptoms come back, that's not post-Lyme syndrome. That's called a relapse. And when I was trained, that happened with pneumonia. We would just retreat people. And then if that didn't work, we would change the antibiotics. So let's apply what we do in medicine commonly to all the things we do. Let's not change it for one infection. And I think it's important. Now, that's different than saying, hey, I got treated for 6 weeks, 30% of my symptoms went away, 70% are there, and I have a persistent problem. Now we can get into this other discussion, right? And then other people say chronic Lyme disease represents it, or persistent Lyme disease is what's causing the ongoing symptoms because we have a persistent infection. So what does the research show? Well, one of the things the research shows is, and John Alcott's group out of Johns Hopkins, post-treatment Lyme syndrome is actually real. When they look at these people, they actually find severe symptoms, but that they can't find a clinically detectable infection. But this is kind of using the standard research criteria, which I went over a moment ago, and it doesn't always pick it up. Then groups like Monica Ember's group at Tulane looked and they said, hey, look, if I infect a monkey for 6 months and then I treat it for 28 days, I cure 0. And if I give it 28 days of IV antibiotics and 56 days of oral, I cure only 27%. And they've done this in 4-month and 6-month increments of infection. So the important part to really remember is that the sooner you get on treatment, the better. Let's not delay diagnosis. Let's not withhold that 3 or 4 weeks of antibiotics in that person who looks like they have acute Lyme, because we may be able to block it from becoming persistent Lyme right at that point. The other thing is the problem, a lot of what happens is we're looking at using different blood tests. and antibodies. And, the thing is, we can infect a monkey artificially, and the antibodies are all over. Every individual responds differently. And they respond differently to different antibodies, right? So they have a different antibody response to Lyme disease. And that different antibody response is variable between individuals. And the other thing is, once we treat those individuals in these studies, we see that it's all bets are off, right? I mean, it's like some of them get worse, their antibodies go up after treatment, then they go down. Some go down, then up. Some don't change at all. It's very variable based on the individual. And that's really what we're seeing here is they're saying each individual host, the monkey or us, shows a very host-dependent signs of infection and a variation in their antibody responses. And then they did find that there's persistent, intact, metabolically active Lyme disease after antibiotic treatment. So the blood test, the standard antibody test, is all over the place. And then when you euthanize the animal and you study the tissue, or you do other tissue sampling or xenodiagnosis, where we basically put a sterile tick on the animal and try to get the animal to infect the tick, we can do that. So we find persistence of infection despite these 4-week courses of antibiotics. And part of the question is why? Well, we know the oldest, the human infection that's most, that's the oldest that we know of is 5,300 plus years ago. Now, the Lyme spirochetes, Borrelia spirochetes, the precursors to current day Borrelia burgdorferi causes Lyme, they've been found in ticks that are amberized, right? Fossils that are over 15 million years old. And rickettsial infections have been found that are over 100 million years old, right? So things like Rocky Mountain spotted fever, anaplasmosis, their progenitors have been around for 100 million years. These things are way older than us. They figured out a way to stick around in humans. They're very complex. They have the most number of plasmids of any bacteria on the planet by double the next closest one. We find a lot of evidence that's been around for a long time that Lyme can go and hang out in places that antibiotics can't get to. It can hide out in immune system privileged places, and it can hide in cells. And then the problem is we can also get multiple infections, which that's a whole different discussion. And that's when we have that co-infection discussion. So some of the more commonly talked about Lyme persisters are a round body, where it basically rolls up into this ball that's protective. It's metabolically changed. Our standard antibiotics don't hit it. It can create a biofilm where you say from the top left to the bottom right, we see kind of the progression, A, B, C, D, E from Dr. Shoppy's lab. And we can see the development of this biofilm where they congregate polysaccharides and lipids, protecting them. Some biofilms have been measured to need 2 to even 500 times a normal antibiotic dose to penetrate it. So we can't just give 200 pills of doxycycline twice a day. So we have to change that up. And we have other protocols to look at that. So when I'm looking at Lyme, especially outside of the early phases, I'm really looking at the spirochete with its cell wall and its intracellular area, looking at round bodies and biofilms. And this is a really important place for us to be, looking with our treatments, because it is something that has been forever really looked at and going, why is Lyme persistent? What is the issue? Why are some people saying, hey, it should go away, and other people aren't? And one of the other things you'll find, though, is we find now is this thing called stationary form. So we're used to thinking about really rapidly growing things, but then there's this sort of dormant, sort of almost like a semi-hibernation state. And what happens is these things metabolically change. So this is not a spirochete, but it is a cell, a schematic of a cell where you're seeing the rapidly reproducing cell and the way it should look at the top. And in the bottom, in the stationary phase where it slows down and its metabolism goes way down and it's ready to persist in you for a long time, we see the bottom one with all these different changes in the cells, in the ribosomes, in the RNA. And the part about here that I didn't mention is, with strep, it reproduces 30 or 40,000 times in three days, and it has a short stationary phase, and then it dies because it's really creates a lot of metabolic waste and then uses up its nutrition, and it essentially burns itself out. Now, recurrent strep can lead to the PANS phenomena, but this is just kind of a description of a single episode. But in Lyme and Bartonella and other things like that, we have Lyme will reproduce like once every day to every like 16 days, according to some authors. Other authors, it's 5 to 21 days. But it's long. It's longer than tuberculosis, right? We treat that for 9 to 18 months. With multiple antibiotics frequently. So Lyme's log phase, its rapid growth is slow. Stationary phase, who knows, that's really long. And I put the space in here because it really can last quite a long time in us. And so that's just something to keep in mind, that these stationary phases are probably one of the reasons that our treatments aren't really working. And the beauty of what's been going on more recently is we have the studies into these stationary phases. Especially at Johns Hopkins, we're seeing a lot of work being done with different medications that have efficacy against both Lyme and Bartonella stationary forms. And we also now have a lot of evidence coming out for the herbs that can be used for the stationary forms of Lyme and the stationary forms of Bartonella. So there's been a lot of talk about things like daptomycin and methylene blue in Lyme, and methylene blue clotrimazole, methylene blue combined with azithromycin or rifampin, and even combining things like azithromycin or rifampin with ciprofloxacin to really hit not only the stationary forms of Bartonella, but their biofilm form. And then on the herbal side, we see that things like cryptolepis and Japanese knotweed, Polygonum cuspidatum, and Chinese skullcap, which is Scutellaria, or a species of Scutellaria, as well as to a lesser degree things like black walnut hull, Juglans nigra, and Uncaria or the cat's claw, really have shown themselves to shine in hitting both growing and non-growing forms. And particularly my top 3 at the moment, really based on that literature, are the cryptolepis, the Japanese knotweed, and the Chinese skullcap, because they're so good in both growing and non-growing forms of both Lyme disease as well as Bartonella. And then on the flip side, we had a recent publication where we saw that for Babesia duncani, which, back in 2017, there was a study that showed that the typical medication treatments for Babesia microti, which is our more common East Coast, Babesia, those were not effective against Babesia duncani. And we certainly see lots of Babesia duncani in the East Coast and on the West Coast. And that we didn't have anything to really help us except what we did clinically to try to figure it out. And now, as of March of 2021, Hopkins put out a study showing cryptolepis and Chinese skullcap are quite effective. And there are some other herbs that are a little less effective, Alcornia and artemisinin and things of that nature come in there. So check out their paper, their studies. They do a really, really nice job of looking at both medications and herbals. And I'm hoping to see that we start to do some studies of the med-herb combinations, because this is a really exciting place. So that's kind of like an overview of what's been going on. And I really wanted to just, as we wrap up Lyme Awareness Month here, I wanted to make sure that we had an opportunity to sort of see some of the pictures, because the last couple of weeks, our special guests have really talked to us about different things we can do and how to prevent it. And we talked about rashes. We talked about some protocols. So go back and watch those, my interview with Dr. Chesney and Dr. Engels. But I really wanted to pop up some slides here so guys would have some references to really take a peek at what we're looking at. And this is, for me, I've been doing this for over a decade, and it's just been such a remarkable 18 months or so. When you take kind of what's gone on in Lyme research in the last 18 to 24 months, and then you drop COVID on top of that, tail end of that, it's been a crazy couple of years. But we've really seen a huge amount of research coming out that not only supports what patients and clinicians are reporting, but they're also showing us finally in the last year and a half new ways, right? And I didn't get into some of the more advanced protocols. Dr. Ligner and Dr. Horowitz have published some really excellent advanced protocols for persistent Lyme. But my goal is to get this information in your hands so that we can prevent Lyme. We can, if we get bitten, we can try to do a prophylactic treatment, because generally they're safe. And when people get on them, it prevents disease. Let's prevent this from happening. And then on top of that, if you get acute Lyme, we need to get treatment early. We don't know between the time of the tick bite and 4 months of infection, we don't have those studies yet, right? So we don't know how long our treatment protocols need to be. But what we should be doing is treating the unique individual in front of us. If they have what looks like Lyme, we should probably be initiating their treatments. And I think that this is a really important thing to remember. Now, the other thing is there's some really great research. Again, Hopkins and some other labs that are working together are coming out with, they actually found in some mouse studies that there can actually be 2 forms of persistent Lyme. One would be late persistent Lyme, and this is what you would think. Somebody got bitten, the diagnosis got missed, or they got treated for a very brief period of time. They had ongoing infection, and months or years later, these symptoms are really bad. That makes sense to most of us, which is why we're all saying let's treat them early. But there's also this potential phenomenon called early persistent Lyme, where a small percentage, a little less than 20% of the ticks are actually having persister forms in them, and they're inoculating the mouse in the study right away with persistent Lyme, with persister forms. So if I start dropping antibiotics and herbs that are for the growing form, but we don't also hit the stationary forms, the biofilm forms, the brown body forms, we're not really going to be as successful, because these people actually have persistent Lyme even though it's early. Or I should say the mice did. And, we need to see more studies. But this phenomena probably happens because when you look at the data on Lyme, people are always like, about 80% of people get better with a short course of treatment. And then when the other 20%, it's like crickets, right? We don't hear about it. So the thing we want to look at is go, hey, maybe this emerging research should cause us to look at it again, look a little different and go, hey, maybe those people who are failing our shorter courses of treatment actually got early persistence of Lyme. Now, we don't know. This is only a small, essentially a pilot study. It's early research. So keep your eyes peeled on that. But it just is really nice to see people are working on it, because this is what patients are experiencing and this is what clinicians are seeing. And we see when we treat these people, we can alleviate their suffering and get rid of a lot of pretty significant problems with these treatments. So my recommendation is to try to prevent Lyme whenever possible, try to get on those early treatments so that we can really minimize the risk of developing persistent Lyme. There may be a role, in my world there is a role, but in some more conventional roles, there might even be a role for doing something like prophylactic treatment or early acute Lyme treatment with something like a doxycycline and combining it with a cryptolepis or a Japanese knotweed. Right, so we're starting to see that, and I would love to see these studies done where we would get the antibiotic and get the herb and see, can we prevent persistent Lyme and effectively treat someone? So maybe a study can be done, and maybe they're even working on it, and I just don't know, where we're getting, hey, it's 3 weeks after the tick bite, we have acute Lyme in the more standard way we're seeing it. Let's treat it. Let's have a control group. Let's have a standard treatment group, and let's do a standard treatment group with some of these herbs that hit persisters, so that now we can know, hey, on these, when we euthanize the animal, and be very thankful that they've sacrificed on our behalf, because it's not like I like animal studies at all, but at the same time, this is information that is just amazing for all people, and even our pet animals too. But we need to know, are they still infected? Because we see that in a lot of the studies, the antibodies, like I was mentioning, go all over the place. They're not reliable. But when they're doing these animal studies and they sacrifice the animal, they're doing tissue studies to confirm that it's still viable organisms that, Borrelia burgdorferi in them. So in this situation, we really know they are still infected despite what their typical antibody pattern would be. So now we can start to test. And a lot of these herbal studies and these persister studies have been done in petri dishes and test tubes. We need to do the next step in a living organism, or we just need to say, hey, we don't want to do any more animal testing. Let's just jump to using these safe herbals in human beings. And so that's what a lot of us have done clinically. So again, I just wanted to really sit down and summarize a lot of the stuff that we've been talking about throughout the month. Let you know there's hope. To me, if you were going to get Lyme and Bartonella or something like that, now is the best time thus far in human history to do it, because we have the best ability to treat you. But nothing beats prevention, and second best is early, solid treatment. So I hope that this can give a lot of information to everybody watching to help with. For any of the practitioners out there, certainly you can check out LymePractitionerCertification.com. I have a webinar series for practitioners that goes into a little more detail with the treatments and such, and how you can apply this in your practice, as well as the evidence that backs it up. Right? Because I don't think we should just get out here and go, oh yeah, let's just do this and do this. I mean, if that's all we got, let's talk about it, because this is a science and art and a practice of medicine. But when we do have that science, let's talk about it and use it, because after all, we claim to be an evidence-based medical society, right? That's what we're all looking for, we're striving for. So let's use that data we have. And I understand that a lot of practitioners don't have all this time to really dive into the little nitty-gritty of all these little things. And I also understand that a lot of the organizations that are pumping out data are really heavily focused on other things, and especially right now on COVID, but we really want to get this in front of all the docs. So if you're a patient, you can share that URL with your doc if they're interested. I'm going to drop the link below. I want to say thank you to everybody for joining me tonight and everybody who's joined us on our other Lyme awareness events. If you have any particular questions, please let me know. And we will certainly get those answered for you in a follow-up video. Again, thanks so very much. This is super awesome. I'm glad everybody could join me. Share this link with friends. And again, go out, have a safe, tick-free summer. Apply some of those things. Don't be afraid of being outside. Go outside and do the things. It's like, when I'll finish with this. When I was young, my mom would always say, be careful. Right when I left the house, be careful crossing the road, be careful driving. And what I know she meant was, be safe. But to me, when I'm talking about being safe, it's a little bit of kind of like, well, be safe, be afraid because the world's coming after you. The ticks are going to get you, right? It's not, it's be safe, be aware. Be aware that there are ticks out there. Be aware there are things that you can do to protect yourself and your family. Be aware that those things involve landscape management, putting things on your person, either repellent or the proper clothing, and then the things you do when you come home. And then you're aware of those symptoms now, so you know what to be looking out for if you happen to miss the tick. And then it's like, be aware and proceed with that awareness, right? And proceed with knowledge and apply that knowledge. So I hope that I was able to share some knowledge with you that you can apply, so that when you go out and be careful, you're actually proceeding with awareness, so that you're not worried as much and you can actually go out and enjoy this amazing summer that we're about to have. So thanks everybody. Happy May, happy Lyme Awareness Month. It's Dr. Tom Moorcroft. I'll see you next time.